I wanted to talk about push-dose epinephrine or push-dose vasopressors, mostly epinephrine specifically, as part of our monthly protocol review for the Southwest Ohio protocols. I actually wanted to talk about this more for the subject of, I think that a lot of folks have heard about this and have been interested in it, but maybe aren't getting what they kind of need in terms of the education on it, or maybe it's been presented a little confused, or maybe the way that we're telling people to do it is a little bit confusing. And so I want to bring up, I think, a little bit better way than you're sort of hearing tossed around the FOAMed world right now about how to make push-dose epi, how to use it, and why it's easier than I think it's been presented as. So I am again including this in with the Southwest Ohio EMS protocol reviews that we do on a monthly basis. This will eventually come from one of the protocols in the protocol book. We are again not officially associated in terms of EMS grounds with the Academy of Medicine of Cincinnati protocols for Southwest Ohio pre-hospital care, but they are certainly friends, and I think they do good work, so I want to give a shout out to them for the great protocols they're putting out there. But you will also find this in many other EMS protocols, such as the Frankfort, Kentucky protocols, which are another set of model protocols that you may be interested in looking at and adopting. So, the protocol this is going to come out of from the Southwest Ohio protocols is SB 205, hypotension and shock. And this is not the entire protocol. This is just a portion of it because I think it can be its own little protocol itself. And I want to hit on that real fast. So, talk about epi real quick. Epi is a vasopressor and an inotrope. You get lots of the pressors that we have. We kind of think, oh, okay, well, they're pressors. They all do the same thing. Well, there's vasopressors, which really just kind of elevate blood pressure, and then there's inotropes, which give you a little bit of more like cardiac activity, cardiac squeeze. Epi does both. Epi's kind of the big thing. It covers all of the receptors, alpha 1, alpha 2, beta 1, beta 2. Kind of hits everything, and maybe at a little bit different concentration, you get different effects. But because it hits all the receptor classes, you get a combination of not only vasopressor activity, like just gives you peripheral squeeze, but you also get cardiac squeeze, and you get some more chronotropy as well, so your heart rate goes up when you give somebody epinephrine. So gives you vasoconstriction peripherally and in the microcirculation. It gives you increased squeeze on your heart, and it gives you increased rate of squeeze, and then also stimulates all the other things like beta 2 as well a little bit, so you can get even a little bit of bronchodilation with it. Epi again hits kind of everything adrenergically. The downsides to use an epi, well, it causes vasoconstriction, and they can cause a lot of vasoconstriction at high doses, such as cardiac arrest dose epi, 1 milligram every 3 minutes or so, causes a significant amount of, say, cerebral vasoconstriction. If somebody's on epi for a long time, it can cause some peripheral vasoconstriction. You notice folks that have been on epi for a long time may get ischemia of their fingertips or of their distal segments. They can get vasoconstriction in their gut. And so being on epi for a long time is sort of a big deal because of that vasoconstriction. The only other thing to keep in mind is epi can increase your myocardial work. So because it makes your heart beat faster, kind of flogs it as hard as it can, it increases the amount of oxygen and increases the stress on the heart potentially. Real quick, onset of IV epinephrine effects is somewhere around 15 to 30 seconds or so. You see it pretty quickly if you give it IV, and effects wear off within about 5 or 10 minutes. So pretty quick on, pretty quick off as well. Now, why is this a thing? Well, the idea was that you've got pressor drips. You can make epi drips, you can make norepi drips, you can make phenylephrine or whatever you want, and give it continuously in these small doses. The reason you may want to do this as a push dose medicine, and push dose means relatively quick, a couple of seconds, dose goes into the IV and then gets a flush behind it, rather than the drip itself, which is the ongoing slow volume stuff. Why would you use the push dose stuff? Well, for one thing, it can take a while to get the drip set up if you even have the medicine sitting around. So if you have an epi drip made, it will even take you a few seconds to prime the tubing and get the pump set up for what you want it to do. So that can take a little bit of time, and some patients are really, really sick and they're hypotensive and they're about to crash, and if you don't, or about to code, and if you don't give them something relatively quickly, if their MAP falls below 45 and stays there for any length of time, there's a good chance that they will go into cardiac arrest or have really bad problems. So you give them a little push dose of epi, which you can theoretically make quickly and have available quickly, so that the patient never really reaches that peri-arrest stage. You sort of pull them back from it, and then you can start the drip whenever that gets there. Other reasons that you might give it would be for a transient loss of blood pressure. So if you've just intubated somebody, given them a lot of paralytic or even a right amount of paralytic and some sedative, and then all of a sudden they're getting positive pressure and they dump their blood pressure right after you intubate them, you may give them a little push dose of epinephrine, bring them back up while you're doing other stuff, either starting fluid on them or, again, getting a drip ready or something like that, changing your vent settings. If it is a transient thing that you need to treat, but you can expect that you won't need the drip after a couple of minutes, then that might be a reason to do a push dose epinephrine. So those are pretty good reasons. That's why it pretty typically gets thrown around there. And also, again, because it's relatively easy to do, you can kind of carry it around in your pocket, make it up real quick, and if somebody's a little hypotensive, and they get a little less hypotensive, and then we can figure out what else we need to do. So folks heard that and thought, well, why don't we do this push dose epi thing too? We have epinephrine available. We're used to using it. We have the tools kind of there. It's not that complicated, so they say. So why don't we ditch the dopamine and we'll just pick up epinephrine, because we've got relatively short transport times, generally speaking, especially if you're just responding to 911 calls. So relatively short transport time. It's going to be a temporary thing. It saves us having to make up a drip, and a lot of times we don't have another option for a drip, like an epi drip or a norepi drip, at least in a practical sort of sense. So this makes a lot of sense for EMS. This again comes from the hypotension and shock protocol, SB 205. It is on the second page of stuff, so if you just look at the first page, you won't see this, but in terms of mixing and making the stuff, here's the instructions for it. It goes on basically one of three ways. So if you have a patient who is in shock, either they're hypotensive, and I'm going to say MAP less than 65 because who knows about a systolic blood pressure, but if they're in shock, otherwise, if you're defining them as in shock, they're cool, clammy, they're bradycardic, or have signs of poor perfusion, if they're peri-arrest, but not completely arrested yet, and assuming that this isn't from hemorrhage, because giving a bunch of epi to somebody in hemorrhagic shock doesn't probably do you a whole lot of good. If the volume's not there, squeezing the pipes a little tighter really doesn't seem to help all that much. So hypotensive or in shock or peri-arrest, and they're not hemorrhaging. So that could be cardiogenic shock as a result of their MI, or distributive shock as a result of their sepsis, or obstructive shock as a result of their massive PE or their pericardial tamponade. Of note, it's really good. This is probably a really good idea in, say, cardiogenic shock, generally speaking. A pretty good idea in distributive shock, as long as you're giving a little bit of fluid as well, or a fair amount of fluid, a decent amount of fluid at the same time to sort of fill the tank back up. And obstructive shock, it's kind of one of those things. It may help. It may not help a lot, but it may be worth a try if you need to support their blood pressure, although there's probably something else that needs to happen if they're in obstructive shock. Okay, so how do you make this stuff up? Well, the way that's commonly described that you'll see people talk about is you take basically 9 mLs of saline. Say you use a flush syringe, and we'll just squirt out 1 ml of it there. So I've now got 9 mLs of saline in here. I have to take 1 ml of epinephrine from my cardiac arrest style epinephrine, 1 to 10,000, or 1 milligram of epinephrine per 10 mLs of solution. And I got to get this stuff out of here, and I got to get 1 ml of it into this syringe of 9 mLs of saline. I then take and shake the thing up a lot and agitate it, and then I've got a solution that's 10 micrograms per milliliter of epinephrine. You give 1 milliliter or 2 milliliters of this solution at a time every couple of minutes until the patient's blood pressure and perfusion gets to where you want it to be. Now, there's just a little problem with that, and that is when you open that box of epinephrine, you end up with, of course, the little plastic holder thing, as well as the vial of epinephrine itself. It is possible to get a milliliter of liquid out of this vial, but most of the time what we're used to doing is popping the tops off, and then we assemble this thing, something like that. And now I've got these 2 syringes. How the hell do I get stuff out of here and into here? And folks try to, squirt a little bit up there, and then they put a blunt tip needle on the end of this thing, and they try to suck out of there, or they may take the needle part and try to inject some of it down into that other syringe, and then you filled up the space already. So it's very difficult to do, to try to use it this way if you don't have a stopcock. It isn't impossible. Probably the easiest thing to do, honestly, is if you've got a blunt tip needle, you can attach it to here, you can puncture through that blue cap on the end of this guy and then suck out your 1 ml of saline. But to me, this is sort of fraught with error, and this is a difficult thing to do in the back of an ambulance. So I'm going to recommend against doing this thing where you make up a syringe of it. Because the other thing too, if you have a significant transport, is you've only then got, if you have correctly done it and you haven't screwed it up, you've then got 10 mLs of this stuff. And you're going to give 1 or 2 mLs every 2 to 5 minutes or so. And so at the end of about 10 minutes, you've exhausted this thing. Or if they get worse, you may give it a little bit more frequently. And you can burn through this this little 10 ml syringe pretty quickly. And now you got to go back and you either got to open another epi or you got to find this thing again and you got to make another solution. Hope you do it right this time. This is hard to do, if you ask me. So what I recommend is sort of option 2. Okay, so the way I would recommend doing it is the following. As you kind of see on the screen here, you take 1 container of epinephrine, 1 milligram of epinephrine in the typical cardiac arrest dose epi format. You can go ahead and open the box, take that thing out, pop the tops, and put it together. So that's 1 milligram of epinephrine, right? That works for me. You then take a 100 ml bag of saline. Standard 100 ml bag of saline. And you squirt this 1 milligram of epinephrine, the whole vial, squirt this whole thing into this 100 ml bag of saline. Now there's a couple ways you can do that. You could get a blunt tip needle and put it on there and inject through the little injection port on the side of the bag. This also, if you've ever taken the green part off, maybe accidentally, this has a little sharp needle on it. You could just squirt it up through there if that'll reach, depending on the style of bag of saline that you have. But nonetheless, you take your whole syringe of epinephrine. There's no measuring and there's nothing like that. You just take the whole thing and you squirt it into the whole 100 ml bag of saline. Cool. That's pretty easy. Throw this in the sharps container. I then shake this up pretty good. Shake, 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 shake. And now I've got a bag of that cardiac arrest, or of that push dose epinephrine ready to go. I can take another syringe and draw up, just using a blunt tip needle, I can draw out 10 mLs, or I could get 5 mLs or 2 mLs, or I can get as much as I want out of this pre-made solution. The nice thing about this is it's a whole syringe of epi into a whole bag. You don't have to worry about withdrawing anything or losing stuff. And you could say, well, that actually makes 110 mLs, and so the thing is not quite 10 micrograms per milliliter. Yeah, I know, but it's close enough, and I don't really care that much about it. The little extra 10 mLs change in concentration will be just fine. Now I've got this big bag that I could use for a 45-minute transport. I could get this guy all the way from the middle of Stanton, Kentucky into Lexington with just what I've got in this bag, give an epi every couple of minutes or so. The other thing you could do with that is take your 100 ml bag and inject, if you have a multi-dose vial of epinephrine, you could inject just 1 ml, 1 milligram of epi into that 100 ml bag, and that still gives you 10 mics per ml. So that works out pretty well. Don't forget to slap the label on it. Be careful with it. How often, again, are you going to give that stuff after you've labeled it? You're going to give a half ml to 2 mLs IV every 2 to 5 minutes as needed. And this is not going to probably raise your blood pressure from, a MAP or a systolic of 70 up to 180 like you would get if you gave them a whole milliliter of fluid. What this will probably do is, systolic is 70, we give them an ml or 2 mLs, and their systolic goes up to 85. You give them another ml and it goes up to 95, something like that. And their heart rate goes up a little bit. It hopefully is not going to be the thing that, again, pushes you from 50 to 150. It's little incremental things. So this may take more than one dose to get to where you really ideally want the person. So you may have to repeat it in a couple of minutes. But 2 mLs every 3 to 5 minutes or so will eventually get you to where you want to be. One more time, how to do this stuff. Option 1, we take standard cardiac arrest dose epi, we take a 10 ml syringe, you somehow get 1 ml of this into here and then add 9 mLs of saline. Again, difficult. Get your stuff out. Get somebody, get the training officer at your station together so you can figure out how you're going to do this stuff so everybody does it basically the same way. I think that's very complicated, so what I would recommend instead is you take this box, take the medication out of that box, inject the entire quantity of that syringe or that Abiject into a 100 ml bag of saline. Shake it up and you're good to go. And then again, how much are you going to give? About 2 mLs, 1 to 2 mLs every 3 to 5 minutes or so. So that should be enough to raise a patient's blood pressure a little bit. It saves you having to set up a drip. It saves you messing with the dopamine. Maybe we can finally get rid of dopamine for the most part. And again, from an EMS side, we're basically temporary care, although we should be really aggressive temporary care, but maybe the whole work of setting up an epi drip is not worth it for the 15-minute transport when we could give the equivalent amount just through little pushes of epinephrine. So that can be a little bit confusing. Sit down again with the folks at your department, figure out which way works best for you so that you know that you're set, and you then do it the same way each time. So if you have any questions, give us a holler. Thanks much.